This is RTP180.
So our very first question here is, of course, on the piece of paper that's the hardest for me to get to. For Dr. McCormack, do potential negative satisfaction scores in hospitals or doctor's offices ever influence the prescription of opioids?
So the short answer to that is I hope not. And I think the reason why someone may have asked this question is because there are certain physicians that are paid with a formula that includes satisfaction ratings in them. It's called value-based purchasing. And the incentive there is to make sure you're not just paying doctors on volume and you're paying them on quality. But one of the patient satisfaction quality questions asks people when they're in the hospital and the doctor's office, how often is your pain well controlled? So some people are concerned that this might create a perverse incentive for people to prescribe more. And so I think this is an open question. I think the data that I've seen is mixed on it, and I think it's a really important issue to continue to study. Thank you.
Thank you, Dr. McCormack. Next question is for Dr. Dasgupta. So we'll pass the mic to him. From a physiological standpoint, how long does it take a human body to become addicted to opioids?
So it's a good question, and I'll pick at the semantics for a second, in that addiction has a component of physiological dependence, so you need to take more to keep feeling normal, to keep getting high. But addiction also has a component of doing other things to screw up your life. Whereas, so when people take opioids for pain, and they take it, day after day, they will get that dependence. But if they're getting it and taking it as prescribed or close to that, they're not going to run into much problems. And so that process of building the tolerance can take a couple weeks. But in terms of the addiction, so the people who usually have mental illness and other kind of predisposing factors may try an opioid and really like it the first time, and they may quickly progress in a couple weeks to some sort of an addiction. But a lot of other people who take opioids for the first time hate it. So it's not a simple question.
Yeah, I've had them for surgeries in the past. I despise them, but some people get addicted very, very quickly. Next question is for Mr. Luganow. How could someone tell if someone close to them is addicted or using opioids?
Yeah, so much like he just said, a lot of the things that we see are those negative behaviors, and what that might look like is the consequences of addiction. So the person is spending inordinate amounts of money to procure drugs, money that they would spend on providing groceries for their children or rent or whatever that may look like. So there's a list of criteria that would show that. Folks that are here drinking bombshell beers tonight might not suffer the consequences of addiction, but if they continue to use, and if they didn't wake up in the morning and they couldn't make it to work and then they were calling in, that's when we start to see real issues, and that can compound and of course combined with the physiological component the doctor was talking about is when we really see addiction cement in individuals.
Certainly. So the behavior is as big of a component as the actual amount of the drug that they're using.
That's correct.
Next question is for Mr. Bajorek. From a government perspective, how can the government and national public health services help local entities that are struggling with opioid epidemic?
Well, if you look, North Carolina has a great strategic plan that they're trying to implement, and it's kind of a 3 pillars. One is prevention, treatment, and recovery, and then law enforcement. You need all 3 of those things, and you probably won't hear a 35-year bureaucrat say, but money is not going to solve everything. Sam Quinones has written a great book, if you haven't read it, Dreamland, and it's the story of how the opioid epidemic got started. And he says that really what's going to resolve this is the community stepping in and taking responsibility for each other. And I really think that's the answer, is that we'll need all these other things, but we have to start looking out and taking care of each other.
Excellent point. So we have a question that's come in through social media. This is our first social media question, so get your feather dusters ready. I will choose someone who has volunteered to answer this one to give us an answer. Real ultimate power, folks. So from social media, what is the one thing that we can do now to educate others on opioids? Really? Really? All right, Mr. Bajorek. All right, we've got the feather duster, so we'll pass the mic to him. These are all long-term questions we've been asking. What can we do now?
Being the only person that doesn't have any initials behind your name, I can talk all I want over here, because what do I know? But I think it's a matter of talking to people. Talk to your kids, talk to your neighbors, talk to your friends, and try to understand what's going on. Opioids is the poster child for isolation, and I think that's where you get people involved.
Dr. McCormack wants to weigh in as well, so we'll pass the mic down to her before we move on to our next scheduled question.
I think that was a great answer, and part of the reason why I think that is because talking about it and being open about it is what's going to help reduce stigma, and that's what is part of the challenge. So I applaud your answer.
Certainly true, certainly true. Dr. McCormack, you are next up for a scheduled question. What is the best way to dispose of prescribed opioids that you no longer need?
Okay. Well, first of all, I would definitely recommend disposing of them in a responsible manner so that someone else doesn't find them and use them in an irresponsible manner. There are things called medicine take-back programs that are happening at various communities, and they are sponsored like by local law enforcement, and you can go to your pharmacy and drop them off, because some things really shouldn't be flushed. If you want specifics on this, you should go to the FDA website or the Food and Drug Administration or the DEA Drug Enforcement Association website.
Excellent. Good advice for people who have opioids in your medicine cabinet. Dr. Dasgupta, there's a big supply chain from manufacturer of opioid to consumer of opioid. How are opioid prescriptions tracked between different hospitals and healthcare facilities during that life cycle?
So if you're trying to find data for your projects on a local level, you can get data on prescriptions from electronic health records from local hospital chains. At a state level, you can get it from the Prescription Monitoring Program, which is an electronic database that prescribers access before they dispense the drug. And then on a national level, there's this fascinating switch in every pharmacy, in every retail pharmacy, which electronically captures the prescription that's being dispensed and actually captures kind of whether the insurance company is paying for it or not. So those data are aggregated to kind of paint the national picture, extrapolate from a big sample of hospitals. So those are the three kind of layers that are most readily accessed.
Excellent. Mr. Lukenow, next question for you. For those who have friends or relatives struggling, but those friends or relatives are not ready or willing to receive help, what can those who care about them do? What is that next step?
Right. No, that's a good question. We get that a lot. What I would tell most folks is to be there for them when they are ready to make that decision. For a lot of the individuals that we work with, unfortunately, it takes some pretty harsh consequences before it gets to the point where they're ready. But something about human beings, whether we're addicted to a substance or not, we don't like being told what to do. It's called reactance, and we simply will do the opposite. Any of us that have parents know that. So with that, just being loving, being there, and being available, and trying to connect them to help, not enabling them, giving them money that might turn out to be financing their drug use, but being there for a hot meal, a phone call, and just being there.
So that constant presence of support until the person's ready to take that next step.
That's right.
All right. Mr. Bajorek, how does or should a rural community in North Carolina deal with the opioid epidemic in their backyard?
Okay, well, before I answer that question, I just want to put a plug for those of you that live in Cary. We do have a drug drop-off site right over at Town Hall. Feel free to come on, bring it over. No questions asked, and it's very easy. Cary is not necessarily a rural community, but from talking with my colleagues, there's several disadvantages that rural communities are having right now. There's fewer jobs. The jobs that are out there, in most instances, require probably more manual labor than others. And when you're working hard on jobs like that, you have a tendency to be injured or hurt on the job, which means you go to the doctor, which means you get drugs, which means you get, if you don't get better, you get more stronger drugs, and then the cycle just continues to go on. Now, one of the advantages that smaller communities have is that people know each other much, much better. And they take care of each other. There's an example of a program in Nashville, North Carolina, where the police chief has put out that says anybody that has a problem with opioid addiction, just come into the police department, no questions asked, and we will get you help. And there's examples of him buying bus tickets, two-way bus tickets to send them to treatment facilities all over the country so they can get help. And I think, that's, again, we got to take care of our own.
Excellent point. We are all in this together. Social media question number 2. So get your feather dusters ready. Hopefully we'll have someone volunteer in under 30 seconds this time. So the American healthcare system is unique in that it's fragmented. It's very tied to different insurance companies. There's no one system. So how is the lack of public health care affecting how people are able to get treatment for addiction? All right, Mr. Lucanau.
It's really bad.
We've got some hard-hitting commentary here, folks.
We have less and less people that are able to access quality care. With the Cures Act funds that came through the federal government, we've been able to get some people some real evidence-based practice, addiction treatment on a very real level. We can't possibly accommodate as many people who actually need treatment right now. We've got to do a lot more.
Dr. Dasgupta.
I think we're also hamstrung by federal laws in that our focus is on abstinence, getting clean, and stopping use altogether. When we know that addiction isn't something that people just fall into right away, it's a process that they step through. When you're trying to stop using, it's a process you step back through. So when people are trying to reduce their use, maybe just for the weekend, maybe to go to their kid's graduation, whatever it is, right? We should support them. We should celebrate any positive change that they want to make. And so the rules that we have that govern addiction treatment in the United States is all abstinence-oriented. We don't have any sort of intermediate public health response when people just want to start by cutting down. And I think that's a huge gap where if you have to wait until you're ready to go completely off, then you're just going to wait. You're not going to go into treatment. So I think that's a big gap that we have right now.
Certainly, the stories of someone quitting cold turkey are compelling, but not necessarily the common case. Back to the scheduled questions. Dr. McCormack, do you consider marijuana or cannabis to be a form of pain management that could supplement or replace opioids?
So first of all, I'm not a clinician, so wouldn't be giving any medical advice. One of the things I think it's important for people to think about is that you really don't want to be mixing your medication. So I think there are a number of people out there who are exploring the use of cannabis as an alternative. Probably not something that they would want to be doing with opioids. So that's definitely something to keep in mind. I think the evidence is very nascent in this area. Not a lot of studies, maybe a few studies that show it can make a difference in certain conditions, but a lot of this is an open question.
Excellent. Dr. Dasgupta, there are addictions that people are aware of through pop culture, their own experience. There are addictions that are new. What's the difference between a cocaine addiction and an opioid addiction?
So there are two different drugs, and cocaine is something that's a stimulant and has a lot of reinforcing properties that work really quickly. Opioids tend to be more sedating and a little bit more dissociative, like I want to get away from the world. And so the people who tend to really like one or the other tend to have those kinds of personalities and other things that may predispose them. So cocaine addictions tend to look very chaotic, tend to look like people kind of using very quickly and needing it again. The duration of action for cocaine is much shorter, in the span of minutes, whereas with opioids it can be in the span of hours. So there's all these things that combine. One very interesting study that was done in New York City is looking at overdose deaths and the effect of weather. So does weather change cocaine overdose? Is there a difference between cocaine overdose deaths and heroin overdose deaths because of the weather? And they found that there is a difference. With cocaine, in the summertime, people die more from cocaine overdoses because the physiologic load of dehydration, of kind of everything else that comes with a hot environment leads people to get into cardiac arrhythmias much quicker. Whereas an opioid overdose looks more like falling asleep. So not Pulp Fiction. That's probably the biggest problem with the public perception of the opioid crisis.
Excellent. Mr. Lucanau, what is being done to get through to kids on the subject of opioid addiction? How are we, or should we, be educating them if it's any different than adults?
Yeah, I think we should be educating children. We're seeing some monies available for prevention efforts. Unfortunately, there's not enough money for prevention, for treatment, and so really it's whack-a-mole right now. So you'll try to hit one thing and then something else comes up. It's interesting, you were talking about data analytics earlier. We're starting to look at kind of markers that would show us that folks might have a predisposition towards addiction, and these could be physiological markers or behavior markers, and how we can employ the use of teachers or nurses and folks that interface with children on an early level to see if they have those markers and put effective evidence-based practices in place, interventions in place that hopefully avoid the addiction issue altogether.
Better use of data is certainly a theme that's been running throughout everyone's presentation here tonight. So, Mr. Bajorek, now that we've talked about the impact on kids, we've talked about the impact on adults, what age is the age most impacted by the epidemic in our region? Where do you see that impact happening?
I'm not sure about our region, but I can't specifically talk about the town of Cary. And in Cary, it's overwhelmingly white males 21 to 35 years old.
That's interesting. Follow-up question from me. I think the perception is that it might be something for older people. Did that surprise you that it skewed that young?
And the real doctors can address this, but I don't think that's surprising at all in terms of you have kids get injured in sports, they're having trouble at school, and they start down this path.
So social media question number 3. This is for the entire group. I see everyone's got their feather dusters ready. If there's someone who has struggled with an opioid addiction in the past, now opioid is medicine as well as an addictive substance, what treatments are available to them when they undergo a major surgery? All right, Dr. Dasgupta.
So this is a super fascinating question because the entire opioid debate in the 1980s and early 90s was focused around exactly this. People with addictions, what happens? Can we safely treat them with opioids? So opioids can be used in an outpatient way, so you get it from your pharmacy, or it can be used with supervision. So there are ways to monitor more closely people who have had a history of addiction. There are specific molecules, opioid molecules that are less likely to trigger relapses, for lack of a better way to put it. So that can be used. In emergency settings, it should just be any opioid necessary. There isn't any specific kind of inhibition to getting the pain under control. So I think it depends on where, at the point of injury, post-op in the hospital, it can be something where the nurses are monitoring it more closely, and then after release from the hospital, it's a matter of the individual.
That's interesting because as seen in my introduction, one of the worlds that I move in is professional wrestling. And professional wrestling, it's real. No, it's not. Professional wrestling, the wrestlers deal with a pain load that the average person would find intolerable, and you usually see one of two extremes. Either they get very addicted to opioids for that pain management, or they swear off of them, they don't touch them, and then when they have real medical needs, they can't deal with the pain because they're not going to take those. So I assume that that's something that's playing out in emergency rooms all over the country these days with people who have experienced it or been touched by it, not wanting to even touch the stuff because they've seen the ill effects of it. Excellent. So I hope everyone has learned a little something about this problem that we're facing today. Please give a hand to our panel for their expertise. Thank you, everybody.